Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hello, welcome back to our conversation, Unraveled Understanding Chronic Illness. I am Eileen Ruhoy, and I am with my lovely co-host, Dr. David Kaufman.
Welcome back.
And today we're going to talk about headaches. What a general topic.
Right. Very uncommon problem.
Very uncommon.
Very rare. Never hear anyone talk about their headaches.
I want to say it's either the first or second reason why people go to the doctor. Lower back pain, I think, is the number one.
Low back pain, I think, is the highest in the general primary care.
Right, in general primary care, exactly. And then when general primary care doctors can't seem to make a dent in headache improvement, they usually refer to neurologists. And in fact, headache specialty is one of the subspecialties and is a fellowship of neurology.
Right.
So there really is a true subspecialty of headache. And the reason for that, of course, is because there are so many types of headaches and there's so many reasons for headaches. So it's a lot to learn.
Right.
What's your experience with headaches as an internist in general?
Everybody complains about them.
Everyone has a
I mean, certainly in the current practice, the MECFS.
Oh, yeah, for sure.
Long COVID,
Yeah.
septed, chronic complex illness. I would say 80 to 90% of patients have headaches.
Wow. How about in the HIV population? Were there a lot of headaches?
No, but, they had so many other problems, the
Yeah.
headaches. As is so true with all pain syndromes, pain A overshadows pain B, so you don't talk about pain B. So that they may have had headaches. And
Yeah,
just
that's a
not
really good
complain.
point. I mean, sometimes when I even ask a patient if they have headaches, they'll say, well, yeah, every day, but like it's just my normal. It's
Right,
fine.
exactly.
So I'm just used to it. It's tolerable. I've learned to compensate for it. But in our patient population now, I think it's a lot more severe because it's not tolerable. And in fact, it's probably one of the bigger symptoms that impacts their quality of life and their daily living for sure.
And I think it's very important because they're not, as we keep saying over and over in every one of these podcasts, they're not just headaches.
They're never just
They're
headaches.
not just having a headache. Like I
Right.
might have a headache after a difficult day or something. Their
Right.
headache is related usually to some underlying pathology.
Right. What's funny is
neuroanatomy, et cetera.
everyone always thinks it's a brain tumor. Like, oh, it must be a brain tumor. For me, it was,
Yeah.
but usually it isn't, especially in our patients. And I've actually very rarely found a brain tumor with a primary headache concern. Usually there's some level of neurologic deficit that makes
Right.
you think, oh, I better get an MRI. But in general, headaches with a normal neurological examination is thought not to be worrisome, but we actually now know that's not true. In fact, in the EDS world, headaches can be very concerning because it could be related to cranial cervical instability. It could be related to elevated intracranial pressure. It could be related to low intracranial pressure. It could be related to CSF leak.
Right.
So there's so many. It could be related to the venous, compression disorders. So there's so many very concerning reasons why a patient might have headaches.
And that's my point, that it's not a symptom in a vacuum, in a separate silo. It's a symptom that should drive us, the examining physician or whoever, to look for underlying causes that would explain that headache other than a brain tumor, okay?
Right.
And in our patients, it's exactly what you're saying.
Right. And they did studies actually that found that there were, in the ME/CFS patient population, there were actually a higher incidence of migraines. And so that was interesting to me. And that in general, there's a higher incidence of just hyperalgesia. So, feel the perception of more pain, or at least feeling more pain in the ME/CFS population. So something about their pain pathways are altered. So, in fact, there's a greater incidence of the chronic regional pain syndrome and central desensitization. So overall pain syndromes just seem to be a lot more common in chronic disease, specifically ME/CFS were the studies that were done in, but also in our long COVID
Right.
patients.
So I think it might be helpful to viewers and myself, actually, for you as a neurologist, to, in reasonably simple terms, describe the difference between a headache and a migraine. Because this happens all the time with patients. Oh, I have a migraine. And then when I question them, I'm not sure why they're labeling it a migraine.
Yeah, migraines are overused in terms of a diagnosis for sure. Now, there's lots of people with migraines. And sometimes if you have a history of migraines or even a family history of migraines and you have another diagnosis such as fibromyalgia or ME/CFS or long COVID or EDS, then you have what I call a migraine brain. And I know the term has been used elsewhere. I don't know if it's like a real term or not, but if you have a migraine brain, you have a lower threshold to have migraine. And we all have thresholds for things. We have thresholds for migraine, we have thresholds for seizures. If you have a brain, you have the ability to have a migraine, you also have the ability to have a seizure. In fact, there is a spectrum that we refer to as migralepsy, with like migraine on one side of the spectrum and then epilepsy on the other side, because there's a common pathophysiology. And so while we don't really understand what the mechanism is with regards to migraine, we know a couple of things, and we know that there's something called cortical spreading depression. So it sort of starts in one area and then it spreads across the cortex. And that's what, for example, if you have what's considered a classic migraine, which is one with an aura, which the most common aura is, of course, these visual obscurations where you can either have a scotoma or those zigzaggy lines, which are, these, you're shaking your head, yes, so you've gotten them. I certainly get them with these scintillations in there, like flashing lights and stuff, and they sort of spread across your visual field. And that's usually in the occipital cortex, but then it spreads across the cortex, and then it ultimately results in the release of pain molecules. And in fact, the mast cells have been implicated, so it goes back to mast cell activation, which is a very common reason for headaches in some of our patients. And then, in fact, the new class of migraine medications, and only approved for migraine medications, are the CGRP antagonists. And the CGRP is basically a pain molecule. And so it blocks that molecule. So there's a reduction of pain. And the symptoms of migraine, are in terms of a conventional migraine, are, usually unilateral. Usually there's light sensitivity, often noise sensitivity, very often nausea, sometimes even vomiting. And in fact, sometimes the history includes, when I vomit, I feel better. It could be worse with movement. People usually need to go and retreat to a dark room without any noise or light and just lie in bed. Often sleep will resolve it. There are times when there is something called status migrainosis, and so where you just get a migraine and it's hard to come out of, and it just persists, for several days in a row.
So let me ask you a question based on
that. I could tell by your face a question was coming, so I stopped talking.
So many of our patients have this hypersensitivity to stimuli, light and sound in particular. Yeah. So many will wear ear protectors, dark glasses, eye masks, stay in a dark room, but they're not complaining of a headache.
Right.
Could it be that is basically a version of status migraine?
Absolutely. So it's called migraine accompaniment. So a migraine accompaniment are getting symptoms that are associated with migraine without the pain. And I often have to explain this to patients because I'll say to them, I think this is migrainous, how I describe it. And I'll even prescribe migraine medications because that's how you treat them. But they'll say, but I don't have a headache.
Yeah, so this is really interesting. Have you given the CGRP drugs to a patient like that?
It's been a game changer for my
and
patients.
with benefit?
With lots of benefit. The problem, of course...
Can't get them approved.
Exactly. Yeah. I didn't have to tell you because that's the problem that we face every day, right? So I think I've said this before in previous podcasts, but sometimes what I'll do is I'll ask a patient to pay out of... I'll prescribe like 4 tablets, especially of the abortive. So they're both abortive and preventative CGRP antagonists, as they're, triptans were always the abortive to go-to medications. And then, of course, there's a whole bunch of preventative medications. But for the CGRP antagonist class, there are abortive ones and there are preventative ones. And so I will use the abortive ones and I'll prescribe like 4 tablets. And I'll just ask the patient, again, assuming they can, to just pay out of pocket. They are not cheap. So that's the unfortunate part. They're very expensive.
Even on GoodRx, very expensive.
Right. So yeah, exactly. So if they can afford 4, I'll say, try them. If they work, I will go to bat for them with their insurance company and explain that nothing else has helped them, but this has helped them. And so they need to cover. It doesn't always work.
Right.
So I'm not saying that as if this is the way to go around it, but sometimes it's helpful to just gather data points for their insurance company so that you can make a reasonable argument.
So these are the pills, not the injectables.
These are the pills, right. So a lot of the preventatives, yes, you're right. They're monthly injections. And I don't like to start with them, frankly, because, an injection, it's, you have to wait a month for it to really be out of your body. Right. And if you have a mast cell reaction or an adverse effect,
of course.
But regardless, it's sort of nice to know just that with the abortive ones, if they're going to be useful at all, but they are often useful. And that's what's so exciting to be able to use this class of drugs. So if I could just get insurance on board, And oftentimes these patients don't even have a history of migraine, so it's not as if that's their primary diagnosis, which also sort of gets in the way of insurance approval. So, if they do have a history of migraines, I'll add that as a diagnosis code. If they have a family history of migraines, I'll even add it as a diagnosis code. But regardless, I think that these symptoms are migraine accompaniments. And it's because they are so responsive to migraine medications, even the non-CGRP antagonists. I get a lot of relief with the other kinds of migraine meds that I use without, even if they don't have the headache.
That's really interesting. I have not done it. So, I have a lot of patients with this problem, and I have my things that I try to do, mast cell,
right,
LDN, the whole range of things. And I generally believe the primary cause is cranial cervical instability.
Right.
But this sounds like such an obvious choice.
Right. Well, I mean, it could be CCI, right? But it triggers a migraine.
Right, but it still could treat it. It's
absolutely
not going to fix the anatomy, but it may fix
and we do that a lot.
Yeah,
we talk about that, right? Right. Us not being surgeons,
right.
We don't correct the CCI, but we do manage the symptoms due to the CCI, which are mast cell activation, which can lead to migraines and headaches. But also the CCI itself can just lead, especially a migraine brain, to migraine accompaniment symptoms.
Right.
And
so we could get the company interested in a trial.
Right. We need somebody to fund a trial for us. Another migraine accompaniment is vertigo, actually. And there's something called migraine-associated vertigo, which is very responsive to a very common migraine med called topiramate or Topamax, or as we affectionately call it, Dopamax.
Right.
but it's very responsive to that, and it's migraine-associated vertigo. So there's a lot of migraine variants, let's put it that way. There's a lot of migraine accompaniments, so without the pain, but also migraine variants that sometimes have the pain, but sometimes don't.
Yeah.
And then there's all kinds of headache disorders. And so the International Headache Society actually has a very nice classification online that you could see all the different headache syndromes. Some are hemicrania, some are indomethacin responsive. In fact, we call them that, indomethacin responsive headaches. And because they're so responsive to indomethacin. In fact, so much so that if I have any question of the kind of headache it is, especially if it's unilateral and it's not responsive to migraine meds, I'll just try indomethacin, which is an
That sounds like a mast cell related reaction.
Absolutely.
Response.
Yeah. And speaking of the mast cells, obviously the histamine from the mast cells, the brain and the cord has H3 receptors, which are unique to the brain and the cord. And so, it's actually a modulator of histamine. And so it's interesting to me that, and there are mast cells in the brain as well as H1 and H2 and H4. And a lot of these patients are on antihistamines, which are H1, H2 antagonists. And so I always wonder sort of the role of the H3. And I think that even on our listserv, we talk about like the pitolisant, which is the new H3 reverse agonist, I believe it is. And I wonder, and I have never gotten it approved. I've tried it maybe a handful of times. I've stopped even trying. Some pharmacies didn't even have it in stock. It's just not that widely available. It's only indicated for narcolepsy at the moment. But I often wonder how much that can help my patients with headaches too, especially with mast cell activation with proven mast cell activation syndrome. So I think that's another promising drug, though, if we can figure out a way to get it for our patients. So there's a lot of reasons behind it, but we do know that, again, the studies in ME/CFS patients show that there's just a greater incidence of migraines. And now that we know all this anatomical aberration that can happen with connective tissue dysfunction, that clearly results in headache and migraines for sure.
Yeah, I think in terms of the connective tissue issue, that's another example of the incredible importance of history taking, trying to understand when do you get your headache, what makes it worse, what makes it better, what are the triggers, et cetera, and you have to really ask those questions to move it along, figure it out.
And especially for any headache that's related to intracranial pressure, right? So there are very, if it's low pressure, then it's better when you lie down, and it's worse when you stand up. Sometimes it takes a while for that headache to worsen. Of course, it doesn't necessarily have to worsen right away, which can sometimes be a confusing factor when you're getting the history and trying to decide what's going on. Obviously, headaches that are related to elevated pressure are usually worse when you lie down. Though not always. They can just be the same no matter what position you're in. But and we did an episode on IIH, and we talked about some of the other symptoms that are usually coexist with a headache, of course. But so yeah, I agree. The history about the headaches, and I often ask patients to keep a headache journal. so that I know what their triggers are. I know what helps, what makes it worse, what, how did you sleep the night before if you had a headache? What did you eat? What was your stress level? Medications you've taken. Polypharmacy is a very under-recognized
Huge cause of the
cause of
problem.
headaches, for
Right.
sure. And, in fact, there's something called rebound headaches or overuse headaches. When certain pain medications are overused, then you can get what's called an overuse headaches. And those are really difficult to treat because you basically have to go cold turkey on those medications. And of course, most patients don't want to do it because we're usually treating either other pain or something else with
Right.
those medications. But if they really are bothered by their overuse headache, then you sort of have to go cold turkey. And I always say that it gets worse before it gets better. And then because during that time, there could be a rebound type of headache, right? So now you have a rebound headache because where the pain receptors were used to being filled with this molecule from this particular analgesic, they no longer are being filled. So the pain receptors have been upregulated and now they're just empty and they're just going crazy. So I always just sort of warn patients, and I always try to manage expectations of any kind of treatment plan tweaking that I do, that this is what might happen first, but the end goal is that you feel better eventually. But they could be notoriously difficult to treat, for sure, those kinds of headaches. And that's why, I try to watch the polypharmacy. I mean, I'm guilty of it too, because you're just trying to treat symptoms often. And so, I'm always thinking about another medication we can try or another medication I can add. But I always have in the back of my mind of like when we're getting into that like realm of polypharmacy.
Right. And it's not just polypharmacy in terms of the active drug molecule. It's all the excipients that are present in all the pills and in all the supplements. So, you have a patient come in and they're on 10 different supplements and 7 different drugs. Any one of those products could have excipients that are causing histamine release and headaches.
Absolutely. And that's why it's so complicated to figure out the exact cause of a headache in our patients, right? Because there's so many different reasons. But just because of that, though, it still can be responsive to a lot of what we do. I mean, I do a lot of Botox for patients, and that's very helpful for their headaches, and largely because it paralyzes the muscles. Of course, you want to be careful with CCI patients. You don't want to do any kind of neck muscles or the traps even. You want to be careful about Botox, but you could do trigger point injections and occipital nerve blocks, which are just anesthetics. And so they don't necessarily paralyze the muscle, but they do block the pain signal.
Would Botox help migraines?
Botox do help migraine. I mean, that's what their indication is, right? For migraines.
Yeah.
There's a particular migraine protocol that you do.
So I'm clearly ignorant with all this. So Botox is paralyzing muscle.
Correct.
But a migraine is originating in the brain.
Right. So the migraine
brain
physiology is originating in the brain, but the pain, there's spasm of muscle.
So it's the spasm.
Yeah. So again, similar to the CGRP, it blocks the pain. So the Botox seems to help the pain. A lot of my Botox patients still report the aura if they get aura. So not everyone has an aura. Treatment for migraine accompaniments, for sure.
Okay.
But it's interesting how many of my patients who have an aura with their migraine still do see or feel the aura. Sometimes the aura is not visual. Sometimes it's like paresthesias, like tingling of the hands or the legs. Sometimes they actually feel weak on one side of their body. There's a cognitive, I call it a prodrome. I'm not sure it's an aura. Sometimes when they describe it, I think it's more of a prodrome, like a migraine is coming. I mean, the visual aura is the visual symptoms are clearly an aura. Like it's part of the physiology of a migraine. Some of the symptoms that people report, like they're feeling tired or they yawn a lot. I've heard that before. I feel it's more of a prodrome than a true aura, and maybe tomato, right? Who cares? But because regardless, it's still like all part of their migraine experience, I guess. But my point is that it may not, the prodromal kind of symptoms might be responsive to the medications, where sometimes the aura still exists. And in fact, sometimes I think that the aura just means that I'm undertreating, right? So I think about this with seizures as well. Sometimes patients have a prodrome before a seizure, and we'll treat with antiepileptics, and they won't have a generalized tonic-clonic, but they'll still have that feeling like they're going to have a seizure, and it scares them. And I mean, in fact, my migraine patients, I mean, they live a daily life fearful of the next migraine.
Sure.
Because it's terrifying to them, especially that aura, which everyone always thinks they're having a stroke. And I can't tell you how many times when I worked in the hospital and was on call, and the ER would call because the patient was in for a stroke workup, and it turned out just to be a complex migraine, because they can be very scary and appear like stroke. And for sure, if you get a complex migraine, you should go to the ER to make sure you're not having a stroke, because time is brain, and
Right.
if you're having a stroke, we need to know as soon as possible because we can better treat. But they look like strokes, and it's very terrifying. So a lot of patients, they walk around with their abortives. It used to be triptans. Now we've got the CGRP class, but also benzodiazepines, right? So they walk around with their medications in their pockets. And if they have any inkling that something is going to happen in terms of a migraine, they'll just pop a pill actually preemptively, and it just makes them feel better.
So the benzos work as well as
The benzos
to
do work,
prevent
yeah.
or abort it?
Clonazepam is one that's commonly used specifically for migraines, but I'll use the others as well. I like lorazepam.
So again, makes me wonder about mast cell activation.
Yeah, no, for
It's
sure,
great
right? Because these are
mast
mast
cell
cell
stabilizers,
stabilizers,
yeah.
exactly. Which is, there's so much overlap with
Yeah,
all of that, frankly. So much so that I've even started to use some of the typical headache medications for mast cell activation when nothing else seems to be touching it. And sometimes it works. It doesn't always work, but sometimes it does.
Yeah.
It does help. And but there is so much overlap in it that I think it's really important.
I think some of the other complexities in our patients, in addition to everything you're describing, is the hypoperfusion that occurs in POTS, which is basically an ischemia, lack of oxygen to the brain, and it will complain and produce headaches.
Yeah, POTS.
Usually, in my experience, that is not the major complaint. The major complaint is usually brain fog and fatigue. But if you ask enough questions, there's also headaches, and there are also headaches, and that improves as you manage the POTS better.
Absolutely. So hypoperfusion, and there is low flows of cerebral blood, right? So we know with transcranial Doppler studies that there is a lower velocity of blood flow through the cerebral circulation, and so that will definitely contribute certainly to lightheadedness, certainly to cognitive. Definitely. And we know that there is distinct physiology because chronic migraineurs, chronic headaches have these T2 flare hyperintensities on an MRI, which is, considered to be consistent with small vessel disease, right? So, but if you think about those small vessels, and if they're inflamed and not getting enough oxygen, they will collapse. And so you will see the evidence of that with these little foci of the brain parenchyma. And, and radiologists will write, that's, usually consistent with small vessel disease. It depends a little bit on distribution and, of course, how widespread it is. But for the most part, you see a lot of these small foci of hyperintense markers on an MRI. And it just shows that, headaches are just not headaches. Like there's something organic happening. And all of the studies that we've done in the chronic and complex world show us that they have, again, low blood flow, low perfusion. They have POTS, they have mast cell activation. In fact, some of the neuroquants that we do will show increased volume of certain regions of the brain, which is sort of a mast cell effect, right? Because with mast cell activation and degranulation, you get inflammation and edema, not edema in the pathologic sense like you would have with a tumor, for example, but certainly, excessive fluid and infiltration of mediators. And you can see that as an increased volume on some of the neuroquants that we do, and that's a marker of mast cell activation.
I think another issue in terms of other causes related to our patient population especially is in terms of the small vessel disease, this whole issue of microclots and low flow, sludgy, sticky blood is a term I use a lot with patients. And I think it's very real. And sometimes just an 81 milligram asprin can make the difference.
Yeah. Oh, yeah. I know. It's funny how much aspirin can help, right? We have all these fancy drugs at our disposal now, but now, I've been recommending aspirin more often than I ever have before. And I mean, even in the stroke world, they've sort of abandoned aspirin as they still use it, but, we used to think dual therapy was great. Now we know that monotherapy, so Plavix is very commonly used. But aspirin, there was a recent study that came out that showed aspirin reduces, risk of cancer or, but then there are other studies that show that it's got obviously some deleterious effects. But I think aspirin is underrated and underused. And I've been recommending it more. And it is a mast cell stabilizer, which is another reason why I like it. And of course, a lot of our patients develop antiphospholipid antibody syndrome, which of course puts them at greater risk of clots and strokes. And so we put those patients on aspirin.
And can present as headaches.
And can certainly present as headaches, for sure. I mean, headaches are scary, right? Because if you've ever had a headache, it's really hard to go about your day.
Right.
Because it just sort of affects like like it affects your mood. It affects how you interact with your environment, how you interact with people. And it's scary because you wonder what's going on in my brain that I have this headache.
Right.
And it's interesting because a lot of these patients, especially with connective tissue dysfunction, they'll have headaches in the back of their head, especially if they have Chiari, for example. There'll be headaches in the back of the head. Migraines are usually behind the eyeball, so retroorbital, periorbital. It could be forehead. It could be temporal, but it's often unilateral, though not always. Sometimes things like hypoglycemia, and a lot of our patients have a whole lot of metabolic dysfunctions, can have bilateral temporal headaches. And, if you're dehydrated, which a lot of our POTS patients are, of course, because they're hypovolemic, you can have sort of this band of pressure around the head.
Right.
And then, of course, if there's any kind of jugular compression, those headaches can sort of radiate up into the parietal areas even. And so sometimes the location of the headache is really important, but in the end, the workup is the same, right? You need to do imaging, you need to do some lab work.
So what prompts you to do imaging in a patient with headaches?
Well,
and what do you do?
I don't think it's a fair question for me because of my story. I think anyone who complains about a headache, I get them an MRI.
Yeah, fair enough.
Because nobody got me an MRI.
Right.
God damn it. So I probably err on the side of being safe more than other neurologists, frankly. Though as a neurologist, obviously the brain is what you do, and so if someone has a headache, I think it's always appropriate to get an MRI. Frankly,
good. I'm glad to hear you say that. I mean, I'm not a neurologist, but my approach there, as it is with almost everything I do, is the risk of the problem versus the risk of the procedure and the value of the procedure. And I do not consider the cost, at least not till the very end of that calculation. So if a patient has a headache and I'm not sure what's going on, I'm going to do an MRI because there's no risk to that MRI and it may save that patient's life.
Absolutely.
And, your story is a terrible but great example of that, and it shouldn't have been put off. Yeah.
No, exactly. It shouldn't have been put off.
And I just frankly even before I heard your story, it gets me crazy when a patient comes to me and says, well, the neurologist wouldn't do an MRI.
Right.
Why? Well, because he or she said it's too expensive. I mean, that is not our job as far as I'm concerned. I understand the whole issue of stewardship with antibiotics. Right.
Also,
and everything else.
Usually the neurologic exam is normal, so that's what their rationale is for. It's not worth the money of the MRI kind of thing.
I hate to say it, but I understand why. I think it's mostly they don't want to have to fight with the insurance to get approval.
That is true. And it does take a lot of work to order MRIs because even if you can get approval, to even get a prior authorization takes time, takes staff, and it's sort of annoying. You have to sit on the phone for a while.
It's criminal.
What? It is criminal. It's criminal. I know. We should just be able to order what we want to order. Yeah. Right? We're doctors and we went to med school and we have some level of competence.
It's all different. All different.
But yeah, so I generally always get an MRI. I mean, one of my first questions is when was your last MRI? Because sometimes they've already had an MRI. I'm usually, weirdly, maybe not weirdly, I'm usually not the first neurologist that they've seen. And maybe it's because I don't take insurance any longer, so they go to other neurologists who take insurance. And I understand that completely, and I actually support that. I think that's fine. So you often, by the time they've come to me, they've already had a brain MRI. But if not, I always order one.
So a sort of a caution for any healthcare people watching and all patients, and my patients are familiar with my rant on this. Using headaches as an example, too often patients will come and say, well, I have migraines. Mm-hmm. How do you know? Well, that's what I was told. I have migraines. And for most of the time, that's where the discussion stops in other doctor-patient settings. And it's critical to get past that. I don't want to know about your quote diagnosis. I want to know what your symptoms are and all these triggers we just discussed, because you may have migraines, but maybe you have them because of the things we've been talking about. Mm-hmm. Maybe because you're having little microclots or TIAs, or maybe you're having hypoperfusion in POTS. Tell me more. Where's the headache? A favorite example is asking more questions and you discover that they have pain actually in their head, but also down their neck and into their shoulders, and what we call coat hanger pain, mm-hmm. which is a classic, can't say pathognomonic, but almost example or symptom and sign for POTS and hypoperfusion. So it's kind of I want to ask a lot of questions, and I always want to trust what the patient tells me, but I'm not going to take everything at face value. I guess that's the point. That
is the point, and that's why a journal is so helpful.
Right.
Yeah, so I asked them to keep a week's journal of so I have a sense of, and I ask a lot about their sleep and a lot about their diet. I mean, there are some food triggers. I mean, I think, food triggers have been controversial a little bit in the migraine world. Some studies have shown that there really, really is no great evidence that it's largely related to diet, though there are some clear triggers, so like red wine is a known,
Right.
aged cheese is a known trigger. MSG for some people is a known trigger. So there are some, even like deli meats actually, because they have sulfites.
Right.
Yeah,
And all of those triggers could be really mast cell activation triggers.
absolutely, and that's what I think they are.
Yeah.
Ultimately, I think if you talk about a food trigger for migraine, I
Right.
do think there's a mast cell mediator
Exactly.
in there, and so there are food triggers in that regard. Especially if you have mast cell activation, but people like I don't know how much. What do you think about the whole gluten thing? I know.
In terms of headaches?
Yeah.
Well, I'll put it really simply. If they have headaches and they go gluten-free and their headaches are gone, I believe it.
Right. That's exactly my approach. Like I'm not a big gluten-free fanatic at all. I think that for the most part, a lot of people tolerate gluten just fine. But I always say, try not having any gluten and see how your headaches respond. And if it responds, then I'm good.
Yeah.
Like then we don't eat gluten.
I mean, I would expand that to almost every patient with every symptom, that it's probably worth a trial of 6 to 12 weeks of gluten-free. I think it's something we're only beginning to understand. Not that they have celiac. None of these patients have celiac.
Right.
They have gluten hypersensitivity. You don't want to get me started, but I think it's probably from SIBO and leaky gut, and that's what kicks off the hypersensitivity. But the number of patients who have a relief of symptoms on a gluten-free diet and a flare if they go back or cheat or whatever is huge.
Yeah.
It's a big deal.
Yeah. So if that applies to an individual patient, then I'm all about it. But
Right.
I always tell patients if it doesn't change your headaches, then
Yeah,
I
that's
don't. Yeah.
different.
So and I think I apply that to most foods. That I mean, even the low histamine diet, which is so hard for people to follow. But if they found a great benefit for it, I'll support them in any way that I can. But if they found that there was no great benefit and they had a hard time following it, then we try other things. We try medications or other support. So, but I think there are some food triggers, of course, that are related to headaches and sleep. Just like seizures, right? If you don't sleep well, you're at greater risk of migraines. You're at greater risk of seizures. And again, there is that migralepsy kind of spectrum. So I sort of liken the two in terms of what could provoke them. Often I do that a lot. So sleep is really important. So I talk a lot about sleep hygiene. And in fact, some of the headache medications help sleep, like amitriptyline, nortriptyline, for example. They're very helpful for sleep, but they're also helpful for headaches. And I think it's largely because they each, headaches can disrupt sleep, and sleep obviously can cause headaches. So, and then actually morning headaches are caused by obstructive sleep apnea or even central sleep apnea. It's just apnea during sleep because the brain is not getting enough oxygen. And so there's lack of perfusion. And so you wake up in the morning with a headache. It also harkens back to the lymphatic nervous system, the lymphatic system of the brain, which is most active during restorative stages of sleep. And, so, if you're not sleeping and you're apneic during sleep and you're not getting enough oxygen, then the lymphatics are likely not working as effectively or efficiently. And so you wake up with a headache, So I always, not always, but I often do sleep studies, especially if I ask do you snore? Do you wake up with a morning headache? Do you wake up gasping for air? And so I'll do a sleep study to sort of see how restorative their sleep is. So I think all these things can contribute to a milieu that makes you at greater risk of headaches, especially if you have a migraine brain, then you're at greater risk of migraines.
Right.
But not every headache, of course, is a migraine. And I do think the migraine diagnosis is overused. I think it's because it's easier. And to be honest, I think sometimes it's also easier in terms of getting insurance approval for some meds, right? So maybe the headaches are not technically migraines in the way we define them scientifically in neurology, but regardless, having the diagnosis in the patient's chart can sometimes help with the medication approval.
Right. Well, that's why I started out asking, for you, the difference between migraine and headache, quote, regular headache.
I mean, lots of things can cause headaches.
And also why I will not take that diagnosis at face value when a patient first comes in.
And that's important, though, not to take it at face value, because there's you could sleep in the wrong position and wake up with a headache.
Yeah.
If your neck is kinked and you can have radiating pain from your neck up, And that often happens. And sometimes I ask where the pain starts and how it radiates.
Right.
And then if you don't treat it, like what happens to the headache? Does it resolve? Does it self-resolve? Does it get worse? What happens when you move your head? What happens if you try to go for a walk?
Right.
Positional, so there's lots of questions to ask about headaches. And that's why they're a headache specialist, by the way. They devote every appointment to learning all about the headaches. And there's lots of different treatments these days. I mean, there's entire societies and organizations devoted to headaches and headache research. And I actually find them, I get their journals and I really find them interesting. They're fascinating what they're learning and what they're looking at. And all it does is confirm once again that there are so many reasons for headaches.
Right. And so many ways to treat it if you get the right diagnoses.
Right, absolutely. And the headaches that are related to pressure, for example, or CCI, they really do resolve when it's corrected. I mean, we see that all the time at the Chiari Center. I mean, the headache is the number one thing that improves following surgical intervention, which is just fascinating to know, right, when you think about it.
Yeah.
So it's usually not a brain tumor in our patients.
No, that's definitely true. Definitely.
But yeah, so anything else you want to know about headaches?
I think you covered a huge amount. And I learned a bunch of things.
How do you treat them? What's your
as you can tell from what I said, I spend most of my time looking for the underlying cause.
Yeah.
And trying to address
And
that.
you treat the underlying cause.
Yeah, I go really aggressively after that. And to me, the underlying cause can range from leaky gut, leaking LPS, which causes immune activation, chronic inflammation, leaky blood-brain barrier, headaches and fatigue and brain fog, to POTS and hypoperfusion, to obviously CCI, the whole range of things. But I never thought about trying the CGRPs in the hypersensitive stimuli patients without headaches.
Yeah, definitely try them.
Definitely going to try that.
Definitely try. Or any of the migraine meds, frankly. So
great idea.
Because they're migraine accompaniments and they are treated like migraines because it's considered to be the same pathophysiology.
Yeah.
So which is why they are treated the same way.
Yeah, very, very interesting.
Yeah. So headaches are important. One of those symptoms that I like to treat because it does help patients feel better. And again, when they feel better, they're more motivated to do other things, right? To sort of help their recovery. Exactly. So that's what's important.
Anything to reduce the pain. No, seriously.
No, I agree. Well, and like I said already, there were studies that show that our patients have more pain in general. Right. So yeah, reducing pain.
It's another reason, just as we're near the end, that I love low-dose naltrexone. And maybe we should have a separate episode on it, but one of the beauty of low-dose naltrexone is it not only can help fibromyalgia type pain or almost any pain, it reduces inflammation in the brain and can therefore help the headaches and the brain fog and everything else.
Right. And obviously if there's any headaches that with concerning associated symptoms like diplopia, loss of vision, any kind of focal deficit, so weak on one side,
that's
feeling
a different story.
tingling on one side, you can't lift your arm, can't speak, don't know who you are, where you are. Get someone to take you to the emergency room.
Yes, exactly. Urgently and emergently. Yes. No, it's true.
Yeah. All right. Well, that's our podcast on headache. Hope you enjoyed that conversation. That was a lot.
Yeah.
That I said, at least.
Well, you're the neurologist. You should say more.
There's a lot to talk about headaches, but I'm trying to make it relevant to our patients and our audience. So
if you have questions about headaches.
Yeah. Let us know.
Yep, right in.
See you next time.
Bye.